Thank you all for being patient with us. A lot of moving parts and pieces, and I'm not used to technology on this campus. So thank you all for being here. We're going to jump in because we're running a little slow, it looks like. But actually, Rachel, you should be doing this presentation. So we have a few folks on our team here, Rachel and Tia back there, who helped a lot with some of these projects and some of the work we've been doing around mental health and disability. But before we do anything, we are going to transition. We talk about transition if you're in the disability field all the time, and yet we don't actually implement it well. We expect everybody to go from one task to another task to another task. So just bear with me. I do this in all my classes. I want you to sit upright in your chairs, both feet on the floor, in your lap, or on the desk, wherever they're comfortable in front of you. And I want you to take a few deep breaths in through your nose and out through your mouth. Breathing in and breathing out. One more deep breath in and let it go. And one last deep breath in and exhale. And if you want, you can close your eyes and just take a minute here to check in with yourself. Notice how you're feeling. Notice if you're holding on to tension anywhere. Notice if your mind is racing. Just notice how you are right now in this moment without judgment. And as your mind wanders, you can bring your attention to your breath, feeling the cool air coming in, your chest rising, and then the air going out and your chest falling on the exhale. There's nothing for you to be worried about right now. Whatever it is coming next will happen whether you want it to or not. Whatever happened before is done. All we have right now is this present moment. So just relaxing, letting the body take a moment to shift from what we were doing before, what we're going to do now. Take one last deep breath in through the nose, and you can sigh it out and open your eyes and come back. Thank you. Appreciate you doing that with me. That helps me. Hopefully it helps you as well. You call it an arriving activity. Sometimes it's nice to arrive and just check in and see where you're at. And it has a lot to do with mental health. So we will talk about that. So today, my job is to thoroughly depress you. And I am going to try my best to leave you with some hope, but I am going to really focus on some of the challenges that we face around mental health and intellectual and developmental disabilities specifically, but it really covers the entire spectrum of disabilities. My primary focus is going to be on rural issues here in the West, because that affects a lot of our diverse communities, and it affects, a vast population here in the Western US. So what we're going to do, by way of introduction, I guess I should say who I am. I know some of you know who I am. I'm Matt Wappett. I'm the director of the Institute for Disability Research Policy and Practice at Utah State, where Utah's USED. In the past, I've been the principal investigator on the Mental Health and Developmental Disabilities National Training Center. And then I was, before Rachel took it over, the PI on the Utah Mental Health and IDD National Training Initiative grant. I also serve I'm a founding board member of the Mental Health and IDD National Research Council at Johns Hopkins School of Medicine. And my research, especially since 2009, has shifted more towards the direction of mental health, the effects of stress on learning, behavior, and social functioning. So that's going to be a lot of what I focus on today. But I am going to give you a lot of data today. So in terms of the session objectives here, like I said, I'm going to depress you. I'm going to kind of talk about some of the disparities that people with disabilities struggle with around securing mental health services. We're going to talk about some issues related to access to mental health services in Utah and the rural West. And then we'll identify some current issues in the systems around serving this population. And then I'll leave you with some resources here at the end that hopefully will be helpful if you're working in this area. So I know that not everybody here comes from the disability world. So I thought it would be good to start with the definition of intellectual and developmental disabilities, which is what our primary focus is. Although, like I said, a lot of these issues cut across disability categories. But if we go with the NIH, RIP, sorry. I know I shouldn't make comments like that, but I have no filter. So the NIH definition is a severe and long-term disability that can affect cognitive ability, physical functioning, or both. And so this can include intellectual disabilities, but it also includes physical disabilities, and some developmental disabilities also include intellectual and physical components. And so it's a very broad category. People are often surprised when we bring this up because a developmental disability includes something like ADHD, which can be very mild, right, in some cases, to autism, to cerebral palsy, to Down syndrome, to blindness, visual impairment, right, hearing impairments, traumatic brain injury before the age of 21. In fact, any injury that impacts your development before the age of 21 is classified as a developmental disability. Learning disability, fetal alcohol syndrome, cystic fibrosis. Anyway, it's a huge category that we're talking about here, and it captures really the vast majority of people who live with lifelong disabilities. Now, the other thing we want to define are mental health issues. They are different. So mental health issues are, as it says here from the American Psychological Association, mental illnesses. And I prefer, I'll just say this up front, I'm not going to call them mental illness. I don't think that mental illness is an accurate description of what they are. An illness assumes that it can be cured. And in most cases, these are issues that cannot be cured and that people live with throughout their lives. And so, yes, there are medications to help manage the effects, but again, a lot of the field is moving away from illness towards mental health issues, mental health conditions, terminology like that. So when it says mental illness, that's still what the American Psychological Association is calling them, but they're health conditions involving changes in emotion, thinking, and behavior, or a combination. And it usually becomes more acute during times of distress and trauma. And it affects right functioning in social environments, work environments, family, personal. Mental health issues are not related to intelligence. They occur across the population. It doesn't matter if you have a high IQ or a low IQ. The incidence actually is pretty common. Approximately, this says 16 to 20% by the American Psychological Association. If we go to the CDC or the NIH, because they all sort of define this differently, the estimates go up to about a quarter of the population in the US has some sort of mental health issue. A mental health issue can manifest at any age. They're often temporary, so they come and go. They're cyclical in some cases. They are usually amenable to treatment. And again, what it looks like in one person is going to be different than it looks like in another person. The flu looks the same in most of us, right? We get a fever, runny nose, sore throat, aches, right? Everybody kind of experiences the same thing with the flu. A mental health issue is completely different. What depression looks like in me might be different than what depression looks like in you or another person with that condition. Same thing with anxiety, same thing with schizophrenia. A lot of these things that kind of fall in this category vary widely in how they manifest in an individual. So, with that said, one of the things that people with disabilities, and specifically developmental disabilities, struggle with is significant disparities in terms of healthcare and quality of life. And again, this is one of those more depressing sort of things to look at. Most people aren't aware that compared to the general population, people with intellectual and developmental disabilities are 2 times more likely to have cardiovascular disease. We'll talk a little bit about why that is. Asthma, arthritis, a lot of autoimmune conditions are much, much more prevalent in this population. They're 3 times more likely to be hospitalized or visit the ER. And many of those visits, oddly enough, are directly correlated with mental health issues or crisis. And they're 5 times more likely to have diabetes or severe dental health issues. And again, the more we start to understand diabetes related to diet and the fact that people with intellectual and developmental disabilities often have poor diets, that makes sense. And then dental issues, it's very difficult to find dentists that will actually serve this population. And so, and there's a direct correlation between dental health, right, gum health and everything, and your overall physical health. What this adds up to, all these disparities kind of taken together, means that the lifespan of an individual with an intellectual and developmental disability is approximately 20 years shorter than the typical population. So it's kind of sad, kind of depressing, but this kind of adds up and it does make a significant impact on their life. Now, there's a term I'm going to use here, and I used it at the beginning, MHIDD. It's a term we kind of came up with about 8 years ago, and it started to catch on, but mental health and intellectual developmental disability. So when I say MHIDD, that's referring to the combination of both of those. What we find is that the full range of mental health issues that the typically developing population experiences is also experienced by people with disabilities. And yet they are often undiagnosed, underdiagnosed, and untreated. In fact, one of the big issues is that people with disabilities, and the more severe the disability, the more likely it is that this will happen. They go in to see a primary care physician. They express concerns around mental health, and very often primary care providers attribute those issues to the disability itself, not to a mental health issue. This is a phenomenon called diagnostic overshadowing, where somebody with autism may go in and say, I'm anxious or I'm depressed, and they'll say, oh, that's just your autism, right? And as a result, these issues are not addressed within this population. So again, the estimates of how prevalent mental health issues are within the population vary widely. We've really only looked at this with a good depth over the past 20, 25 years. They average between 35 to 60%. More recent research in 2016 is the last really comprehensive study indicated that about 50% of people with IDD have a diagnosable mental health issue. So almost twice the rate that we see in the typical population. So it is a significant issue that people with disabilities are currently facing here in the United States. So what I want to do is I'm going to do something weird here. I'm going to walk you through a longitudinal study that is done in Canada. This is done in Ontario, Canada, but it is the largest populational study of healthcare disparities for people with intellectual and developmental disabilities in the world. And Ontario, Canada, although it has a different health system, their quality of life, their social structure, everything else, their diet, really everything else, even their disability service system is very, very similar to the US. And what we found, although we don't have a large longitudinal study here in the United States, there's one going on right now at the Ohio State University, but they're in the very beginning stages of setting something like this up. But what this study does is it gives us a pretty good snapshot of some of the details of what health and mental health looks like within this population. And it does raise some significant concerns and gives us some data to really understand what's happening here. So when we look at this study, to give you a sense of the size, this is a huge cohort. It's about 66,000 people with intellectual and developmental disabilities they're tracking. And they're taking health data, they're taking social service data. Then they have that middle part, about 20,000 people that they've got both data sources for. But what this does, again, is gives us a picture of some of the issues. So I'm hoping that's not blocking. If I can move those captions. Well, is that moving there? No. It moves on my screen, but not on yours. I'll walk you through this. So when we look at this data, so the red bars are people without disabilities, the blue bars are people with disabilities, and it has different conditions here. So this is really comorbidities, right? You have a disability and a comorbid condition. So congestive heart failure, about twice the typical population. This is chronic obstructive pulmonary disease, about twice the typical population. Diabetes, again, about twice the typical population. Asthma, not quite twice, but pretty big. Hypertension's exactly the same as a typical population. The big one here is psychiatric disorder, which would include most mental health issues. It's, again, twice the typical population, but again, it gets us up around that 50% point for people with intellectual and developmental disabilities. When we dig even further into this data and we look at who are the specialists that people with disabilities are going to see, we see similar trends. So this is kind of all specialists. Against the red bar is people without disabilities, the blue bar is people with. All specialties, we see that people with disabilities are seeing more specialists. And then we try to break it down. This is a gastroenterologist, it's about the same. A neurologist is about twice the typical population. Psychiatrist, 14.9% are seen as psychiatrists compared to 3.1% of people without disabilities. Respirologist, anyway, surgical, others. Well, the surgical one's interesting. People are always like, well, why is surgical lower for people with disabilities? That's also related to ableism within the healthcare system. A lot of people with disabilities, doctors will not operate on and will not pursue more aggressive treatment, especially if they can't communicate, if they have issues getting consent, things like that. And so we see surgery, although it may be helpful, much less within this population. So, okay, so hospitalizations, this is where it gets interesting. And this data mirrors almost exactly what we see in the United States. Again, red is without, blue is with, and we have age brackets here. So again, this is everybody. So no, that's not everybody. That is 18 to 64. So that is overall. Overall hospitalizations are right 6 times greater for people with intellectual and developmental disabilities than the typical population. But as we go up in all the age brackets, 18 to 24, 25 to 34, 35 to 44, 45 to 54, and then 55 to 64, the rates of hospitalization are exponentially higher than the typically developing population. And again, the big reason when we dig into this and we look at why are people getting hospitalized, a big part of it is related to trauma and an inability to manage crisis. They get in crisis, it's difficult to communicate, and the only resource that a lot of these people have is the emergency room. In fact, here in Utah, at the University of Utah Hospital, we have stories that we've gathered, parents taking their children with autism into the ER because they have no other resource, and their kids end up staying in the ER, in an ER room for 2 to 3 weeks at a time because there is nowhere else to put them. There's no crisis centers, there's no inpatient treatment, there's nothing. And so a lot of these people end up in the ER for extended periods of time because there are very few resources to address their mental health issues in crisis. So getting more interesting, medication use. So this is numbers of medications used by people with disabilities. So again, 40% use 0, but as we get up here, right, 13% use 1, 26% use 2 to 4, 13% use 5 to 7, 5.7% use 8 to 10, and then about 3% use 11 plus medications. Now that's fine. We live in a society here in the developed North American world, the weird world. You heard that? Western educated, industrialized, rich, democratic countries. It's kind of the weird world. Medication's very common. So I won't have you raise your hand if you're on 11 plus medications, but it's not uncommon for us to be on multiple medications here. That's kind of what our healthcare system does. The more interesting thing is, what are these medications? So when we dig in here and look at what are these medications that people with disabilities are being prescribed, the blue on this one is non-psychotropic. So this would be medication that is not for a psychiatric issue. The red is psychotropic medications. And so again, we can go with laxatives, right, pretty low, ACE inhibitors for high blood pressure, pretty low, carboxamide anticonvulsants, essentially. Again, low, hyperthyroidism, anticonvulsants here, valproic acid derivatives, antipolemics for cholesterol, proton pump inhibitors, but the highest prescription rates are SSRIs, antidepressants, benzodiazepines, so sedatives, right, for anxiety, and then antipsychotics are the largest number of medications that people with disabilities are being treated with. Antipsychotics are intended to address somebody who is in acute psychosis. Antipsychotics, however, are great at controlling behavior. And behavior is one of the primary manifestations of somebody who's experiencing a mental health issue. So whether that behavior is, right, lethargy, or whether that behavior is aggression, an antipsychotic can help address that. Now, antipsychotics, I don't know how many of you study antipsychotics. Antipsychotics are problematic in many ways. They're not intended to be used long term, and they're typically not intended to be used with other antipsychotics, which, again, when we dig into this data and we look at people with developmental disabilities and how many antipsychotics they're prescribed, and unfortunately you can't see this, is dispensed, 20% are dispensed 2 or more antipsychotics concurrently. Antipsychotics have a lot of interactions, and antipsychotics cause cardiovascular disease, diabetes, metabolic issues. Antipsychotics are typically not intended to be used longer than 4 to 6 weeks. So as we dig into this, dispensed antipsychotics continuously for 3 months, about 12%, about twice the extent of time they're typically prescribed in the typical population. And then about 7.5% are dispensed the same antipsychotics for more than 6 months. And again, the longer you're on these drugs, the more likely it is you're going to have some of the side effects. And again, when it's 2 or more and they're interacting one against another, we see a huge increase the longer you're on them in heart attacks, strokes, other cardiovascular issues. In fact, in other studies, right, 19% here in another study were dispensed 2 or more antipsychotics concurrently, and then over 1/3 of children with IDD receive antipsychotics instead of a behavioral intervention. They get an antipsychotic and there's no attempt to actually address, right, behavior change. And then because the antipsychotic's easy, right? Give them a pill and they stop acting out. They essentially end up in a daze, unfortunately. So there are some significant issues here. The other issue is that this really came to a head, and we saw a lot more interest in this field with COVID, and we all experienced mental health issues during COVID. In fact, we started to talk about mental health more as a society during the pandemic, but we especially saw a huge increase in this population because all of a sudden people lost their supports, family members died, they lost their routine, they maybe lost friends, they became socially isolated, the same things that we all experienced. And yet, if you have an intellectual or developmental disability and you require a family member to provide care, or you require a disability service provider, right, to do your services, and you don't have that, it can create a huge disruption in your life. And we saw the same sort of rise in mental health issues among caregivers. And so, again, a lot of money started to come out around the COVID pandemic for mental health in general, a lot more in this area, but really, again, if we're going to look at when people have been trying to address this, it's really only been within the last 10 years that there's been a concerted effort to kind of gather data and figure out what's happening with this population. So let's talk a little bit about Utah specific data. And again, although this data was gathered in Utah through several projects that we've had at the Institute for Disability, a lot of these trends hold true when we look at data from other states. And so again, if you're not from Utah, maybe consider what this might look like in your community. In Utah specific data, back in 2018, we did a study looking at rural healthcare issues. And we surveyed rural counties across the state of Utah and really asked them what are their primary healthcare issues. And we specifically pulled out people with disabilities. And in rural healthcare here in Utah, the two top issues that came up back in 2018 before the pandemic were alcohol and substance abuse and mental health issues. Again, followed by cancer, underage alcohol, obesity, diabetes, child abuse, tobacco, personal health. Anyway, kind of down. Lack of access to healthcare is about 41%. But mental health, and again, alcohol and substance abuse being directly related to mental health. Again, alcohol and substance abuse is a mental health issue. It's also a way of people self-medicating to address mental health issues. So those kind of combine together to indicate that in rural areas, this is a huge concern. If we look at my favorite databases data, BARFs data. You all familiar with BARFs? All your states gather it if you're not. And every state gathers a little different data set. A few years ago, Rachel Eduardo, who puts this conference who helped put this together, helped us on this. We went and got the BARFs data to look at what mental health might look among people with disabilities here in the state. So again, blue is any disability, red is no disability. On this particular slide, this is the 2020 data. So right before the pandemic, we saw that ever had depression. This is among adults with disabilities 18 years of age or more. You see twice the number of people with disabilities had depression than people without. So again, very much in line with the trends that we see nationwide and sort of the projections that the rate of mental health issues is twice the typical population. And this one, looking at mentally unhealthy days in the past 30 days, this one's really interesting. 0 days, again, zero disabilities had 0 days. And again, we had about 35% of people with disabilities had zero mentally unhealthy days. 1 to 13 days, again, people with disabilities are lower a little bit than the typical population, but 14 plus days, we find people with disabilities much, much higher than the typical population, which indicates that a lot of these people with disabilities are struggling long-term with these mental health challenges, and they are not being addressed effectively. In the same landscape analysis that we did here in the state, when we looked at sort of what are the symptoms of anxiety or depression that people experience, people with disabilities experience, this was a survey that went out. We only had 91 people with disabilities in the state of Utah, but again, a pretty representative and similar sample to what we'd see based upon the other research. So again, 64% showing they're tired or unmotivated often, feeling sad or down, 56%, having trouble concentrating or confused. Anyway, these are sort of all diagnostic criteria for depression or anxiety. The sad one is behind this. Thoughts of suicide or death. 22% of people with disabilities experience suicidal ideation points. So when we look at disability service providers, because they're often the first line of defense, a lot of people, especially adults with disabilities, receive day services, other services from disability service providers across the state. When we surveyed disability service providers, 192 of them here in the state of Utah, approximately 84% said that they've worked with an adult with a developmental disability whose mental health concerns were not adequately addressed. So, how are you feeling? It's kind of sad. But it is, unless we paint the picture, unless we really show how, I think, how pressing some of these issues are, it's really hard to get people to pay attention to them, because a lot of these people with disabilities, in many cases, and especially in rural areas, are out of sight and out of mind. And so what are some of the barriers to actually getting them into services? Well, again, I'll go through a few studies that we've done. We did a survey again back in 2018, the same one in rural counties. 80% of survey respondents indicated that mental health issues are a significant concern in their communities, like I showed you. 67% had insurance that covered mental health care, but 77% said they did not have people within their community healthcare providers, mental health professionals in their community that would accept their insurance plan. So although people had insurance, some did, there's very few providers to actually who will take that insurance. And again, Medicaid's a big one. Medicaid reimbursement rates are very low, and it's very hard to find mental health providers who will actually take Medicaid. Some of the other big barriers, again, when we look at what are kind of the two primary barriers, it's again, lack of providers. It's hard to get providers to practice in rural areas. And then lack of insurance coverage was another big one. But the bigger one, and again, this is something we struggle with as a society in general, is that stigma around mental health issues leads potential patients to avoid pursuing treatment because they're afraid of the judgment, how people will talk. Again, we're still not great as a society at saying, I have depression, I have anxiety, and actually expressing that, especially as a male in the West, is very hard. So, so that when we look at, so I actually have some comments here that I think are indicative of this. From the same study, we did interviews and asked people about some of these barriers. The first one's really access to care, just to kind of give you a sense of what this looks like in the life of a family. We're 65 miles from the nearest hospital and are located along two major drug corridors, I-70 and I-15. I-15 comes from LA all the way up through Salt Lake. There's nothing for the youth in this community to do to dissuade them from risky behavior. Most caregivers work 2 or more jobs to support their families, leaving youth alone on their own to their own devices. No movie theaters, no other means of entertainment. Leaves plenty of room for alcohol consumption, substance abuse in both youth and adults. Having to travel such a distance for healthcare and specialized healthcare is a hardship. The community being so secluded and rural makes abuse and illegal activity difficult, if not impossible, to have one neighbor report on another. So much goes unreported. And another one, I think that's even more concerning. Although we have a local pharmacy, I choose to travel over 150 miles to a neighboring community to pick up my depression medications because the pharmacist goes to church with us, and I don't want him to tell others in the congregation that I'm struggling with my mental health. I know he's not supposed to talk about it, but our community is so small and closely knit that confidentiality doesn't really exist. I'd rather travel 4 hours to get my medication than deal with the judgment of the community. It's a huge issue. It's a huge issue, not just for people with disabilities, but also for everybody else within these communities. And it's something that's not talked about. It's something that's avoided. It's something, again, that's often out of sight, out of mind. Going back to the first one, this lack of social support, this lack of things for people to do is really, really important. And it's especially important when we think about the population of people with disabilities. What is the number one factor? When you look at somebody and you want to know if they're going to be mentally healthy or resilient, what do you think the number one factor is?
Like support?
Support. Yeah, absolutely. Do you have social support? Do you have family, friends, or others who will care about you, who you can rely on in times of crisis and distress? A lot of people who live in rural areas are completely isolated. They don't have that social support. Their family may be gone working. Many families commute, right, 100 miles or more to a job. And so people are left alone for a long period of time, which further exacerbates mental health issues that folks may experience in these communities. Going to our 2023 study, which we completed at the end of COVID and right before, again, going to disability service providers, we asked them, is it difficult to find a mental health provider for an adult with a developmental disability in your area? 79% said yes. And to further, almost 3 out of 4, almost 3/4 said they tried to refer an adult with developmental disabilities to a mental health provider, and they were turned away or denied because that mental health provider would say, I'm not trained to work with that population. I don't know how to deal with people with autism, people with cerebral palsy, whatever the case may be. And so I'm not going to serve them. And so there's a lot of factors here to play together to create the perfect storm here in terms of addressing the needs of this population. One of the things that happened within the West here that led to this was going all the way back to 2008. We go back to the economic crisis in 2008. One of the things that we saw when we look at census data is there was a huge outmigration of people from our rural communities in the West. And this was across Idaho, Nevada, Utah, Arizona, New Mexico, Montana. People couldn't get work in rural communities, and so they relocated to be closer to urban areas, which made it even harder to get health providers to go out to these areas because there's fewer people to serve. So, and that has continued. In fact, many of those communities have still not rebuilt, and many of those communities, if you drive through the rural West, you'll find there's a lot of communities with empty buildings just sitting there. There's not, and this happens in the Midwest as well. If you drive across the Midwest, there are small rural communities that are dying. And unfortunately, as a result of that, there's just not the market to bring in healthcare providers. So 58% of survey respondents, as I mentioned, said they had to drive 50 or 100 miles to the nearest clinic or hospital. And again, this economic feasibility. So again, it's a perfect storm of issues that are making it really, really common for people in rural areas to find mental health supports. Okay. When we look at mental health provider sort of availability across the West, it varies widely. And again, this isn't just Utah, this is in the Intermountain West. When we look at data on, and there's actually several good sources of this looking at how many providers per individual are there. So in rural communities, it can be anywhere from 2,000 people to one provider to 244 people to one provider. So it varies widely. There are some communities that have a strong healthcare system, and there's others that have nothing. The urban average, again, is 567 to 1. The vast majority of rural communities are somewhere towards the upper end of this. So the vast majority actually end up around 1,000 to 1,500 people per one provider, which is much, much more than a single provider can typically handle. And so the other thing that comes up in these conversations is, well, what about telehealth? The COVID pandemic led to more acceptance of telehealth technology, and doctors started to offer this as an option. I don't know how many of you have used telehealth. Okay, a pretty good portion, way more than it would have been before the pandemic. The interesting thing is when we look at these rural communities and we ask them about telehealth, they are not using it, even though it may be available. And a big reason for that is there's infrastructure issues. A lot of these areas may not have cell service, may not have internet. Again, Utah, Idaho, Nevada has some of the worst and slowest internet. In fact, the slowest internet in the United States is just north of Moscow, Idaho, and Potlatch, Idaho. Just in case, just random trivia. But there's also a significant mistrust of technology, and we actually saw this firsthand at the Institute for Disability. One of the programs we run is an early intervention program. And so we run the early intervention program up in the northern part of the state, up to 3. And we also run the early intervention program down in the southwest of the state. So Moab, Price, Carbon County, that area. We started to use telehealth much, much more for these early intervention visits during the pandemic. But we found that folks in that rural, that southeast portion of our state were not able to take advantage of it. So we saw a huge drop off. And when we asked people why, a big part, well, I don't trust, I want you to come out and see me in person. Well, we can't come out and see you in person. Okay, well, then we don't want the services. And we saw a huge drop off. Whereas in urban areas, so like in up to 3, in the northern part of the state, we saw a huge increase because it's accessible, it's available, people trusted it, and it was okay. And so in these rural areas, even though telehealth may be available, there may not be the infrastructure and there may not be the trust in people to actually use it, or even the knowledge or somebody there to train folks on how to use it. So, oh boy, so depressing. One of the other big issues that we struggle with this population is that people with disabilities, more so than any other group in the United States, have to navigate multiple government systems. It's not, you know, if you have typically developing kids, usually the school system is the only system you have to interact with. Maybe healthcare, for when your kids get sick. But when you have a child with significant intellectual disability or developmental disability, you have to navigate potentially Social Security, Medicaid, right? Home and community-based services. You may have to navigate vocational rehabilitation as your kid gets older. Mental health is another one that you can navigate. And so people with disabilities have to navigate all of these systems and these government regulations in order to get services. So again, as I say here, the three primary ones are the medical system, the intellectual developmental disability system, and the mental health system. The philosophy and funding for each system are different. And actually here in Utah, if you have a developmental disability, depending on where you live, you may not even be able to get services through the state. The state of Utah here has a system where the local mental health authorities can determine who they want to serve. And so if you have autism, for example, and you have a mental health issue and you want to go to the local mental health authority to get services, if you are in Park City or down here in Salt Lake, you can get services. They've taken advantage of what's called an autism carve-out. If you're in Logan, or if you're in other rural areas of the state and you go in and they say, oh, your primary diagnosis is autism, they'll say, oh, we don't serve you at all. They've just completely carved that out. And so there's systemic choices that are made by the folks who run these systems, and the philosophy and who owns the people and how do you help them navigate and coordinate care and everything is incredibly complex. And we don't have good support. We're helping people navigate these coordinating the care between these systems. And for example, DD services, you have a support coordinator that will coordinate your care for DD services. If you're in the school, right, you have your IEP team who will help you coordinate care. If you're in the mental health, you'd have to have another team. And those teams don't talk one with another. And yet mental health issues affect, right, DD services. Mental health issues affect how a child behaves and performs within school. And so it becomes, again, increasingly complex when we look at how our systems are currently set up. And they are not set up to help people with disabilities access those mental health services that they need. So what do we do about it? So what are some of the things we do about it? As I mentioned, it's really only been within the past 10 years that systems have started to make attempts to address some of these issues. And so we don't have really good data on what works and what doesn't work. We have small pilot projects here and there. New York has a good pilot project. Los Angeles has a good pilot project. Seattle has a great pilot project where they have some services and supports, and yet it's disparate and it tends to be located within large urban areas, which isn't great for those of us who live in the West here. But what we do know over and over and over again, and this is something that we reinforce through a lot of our programs, is that awareness and a proactive approach to coordinating care is vital to meeting the needs of people with mental health and IDD. And I know that's a broad generality, so I'm going to explain that a little bit more. The other thing that we know, though, too, is although there's very few randomized controlled trials and clinical sort of studies that demonstrate what's effective, there is a really well-established body of research that shows that a medical home or an integrated care model is beneficial for this population. And what does that look like? Well, we have very few of these as well. We have one here in the state of Utah that does pretty good. At the Huntsman Mental Health Institute, there's the Neurobehavior Home Clinic, which some of you are familiar with. They do a good job at this, but again, they're hit and miss. But really what an integrated care model requires is that there is somebody helping these families and these individuals navigate the many systems that they have to work within. So again, we need to coordinate that mental health system, education, DD services, family and social supports, physical health care, community supports, right? In order to ensure, because The way that you interact with your community affects your mental health. Your physical health affects your mental health. How you engage in school and how supported you feel in school affects your mental health. Do you have somebody who's going to help you, right? Get up in the morning and get out and take your medications, DD services, right? That affects your mental health. All of these things, and that's what makes mental health differently. With the flu or other, right, diseases, we can oftentimes take medications and we just wait and it goes away. Mental health issues don't go away in many cases. They can be managed, but they don't go away. And it requires getting these systems to work together, to talk together, to coordinate together in order to actually help support the mental health of this particular population. Okay. One of the other huge, I think, misconceptions about mental health in this population is that typical treatments will not work. And that is patently false. That is patently false. And again, going back to what Darren talked about earlier today, people with disabilities are whole people. They have dreams, they have desires, they have aspirations. You like to have friends, they like to have friends. You like to have a job, they like to have a job. You need to talk to people, they need to talk to people. So really, there's nothing there that makes this population any different than any of the rest of us, except for maybe you have to change the way you communicate. You may have to simplify your language. And yet when we look at smaller studies that are starting to come out, we find that the typical mental health treatments work with this population. There's no magic bullet. There's nothing that says, oh, you have to use a special approach to address mental health issues. We know that applied behavior analysis, a lot of evidence behind that. Working on applied behavior analysis instead of going on psychotropic medications, okay, is incredibly effective. Cognitive behavioral therapy, talking through your issues. When you talk through your issues and you're able to exercise control over your emotions, you're putting it into words, it makes a difference in how you feel about controlling those emotions. Acceptance and commitment therapy, mindfulness, physical exercise, all of these things work. And yet when we talk to mental health providers and others, well, I'm not trained to work with this population. And yet they're all trained in a lot of these. And yet there's a lack of creativity and thinking, how do I adapt these treatment modalities to address the needs of a population that maybe communicates differently, that maybe interacts socially a little bit differently. So I know I'm running out of time. I'm getting the notes. So a couple of initiatives driving change here in the state, just to leave you with a little hope. So there are a few things we're doing here, and I'm happy to hang out after and talk. Rachel's back there, Tia's back there. They're happy to talk to you about this too. Some of the things that we're doing here in Utah to address some of these issues, we're currently providing training for disability and mental health providers on meeting the needs of this population, trying to share this information, trying to help them recognize that we have a shared responsibility to meet the needs of this population. We have an accessibility and healthcare project with the Department of Health and Human Services that we're working on, where we're trying to make local health authorities a little more accessible, not just physically accessible, but also cognitively accessible for people with disabilities. We're working with the Utah Mental Health Counselors Association and DOPL, the Division of Public Licensing, to get licensing requirements and professional development to include training on disability, right? Take at least one continuing ed class a year on working with people with disabilities. And that makes a big difference in how confident a provider feels about meeting the needs of this population. And then on the bigger end, we have a community of practice that we're working on right now with stakeholders from around the state, from model programs from the state agencies, to look at how do we change some of these systemic issues that we're facing. Now, I want to reiterate, these systemic issues that we're facing are not unique to Utah. We look at these systemic issues across states, and yes, Medicaid and all these other systems differ widely, and yet they're all facing the same issues in the rural West. So I will send out these, I'll send Mindy this PowerPoint, and you can link to these. We have some online resources. There's a couple of courses. This is from a USDA grant that we had a few years ago, where we developed resources on rural mental health. And so it's specifically targeted at farmers and ranchers, and yet primarily what it addresses is the rural health issues. And so a bunch of links there, right? Personal wellness, wellness as a couple, wellness as a family. There's training on mental health awareness for agricultural workers, but again, a lot of the principles actually apply across the board. And then we also have some online resources that are being developed now. We have acceptance and commitment therapy treatments that are being piloted. Rachel, Ty Aller at our office and others are developing these. So a guide on acceptance and commitment therapy for chronic health conditions, acceptance and commitment therapy for children of parents of children, acceptance and commitment therapy of life, the shortened version, specifically piloted for people with autism. We have a mental health awareness and advocacy for direct support professionals, people who are working directly with people with disabilities that Rachel can talk to you all about. We have one for employment support professionals who are working with people with disabilities in employment settings, and then one for youth, including youth with disabilities. So with that said, there is a huge need for change. And I know there's a lot of change going on now in our country and our world. And yet this is a part of our system that we need to be aware of and that we really need to advocate and work for change. As Winston Churchill said, to improve is to change, to be perfect is to change often. So with that, I thank you for listening, and I'll hang around for questions after. Thank you.